Good morning, everyone, and welcome to this workshop. So I'll be just talking about some of the common imaging modalities in neovascular AMD and speaking a bit on slides are not moving. Sorry. So this is the flow of the talk. We'll be basically concentrating on FFA, Icg, and OCT. And we'll discuss, of course, multimodal imaging and something about biomarkers and a little bit about introduction to the new kid, although it's no longer so new, but the relatively new kid on the block, OCTA or OCT angiography. So I think first important thing is that we should not forget the importance of a clinical examination. So the humble color photo or the 90D gives us a lot of clues to the disease entity. And I'll be discussing this further, but this is something which we must look at as soon as the patient comes into our clinic. So role of imaging, of course, is to diagnose the AME, define activity, recognize the variants like RAP, PCV, formulate management protocol, reassess non-responders. So these are even more important to image the patients who don't do so well and to decide the cessation of the treatment. I'll be mostly concentrating today on the diagnosis part because management will be taken up by subsequent speakers. So classically, the dye-based angiography is what we used. Fluorescent angiography is, of course, the gold standard, shows leakage through the abnormal endothelium of the CNV and staining of additional tissue of RP. And it's useful for diagnosing AMD, especially in cases where there may be uveitic scars. Along with that, there may be CSR or diabetic retinopathy because you can have multiple entities. So this helps us distinguish the lesions from each other and very useful for type 3 CNVM. So these are the characteristics. You can see hard drusen, soft drusen, geographic atrophy, and the CNV. Let's see a few examples. The classic CNVM is characteristic by the lacy network. So you can see this lacy network coming up on the FFA. And where the RP is defective, you will have a window defect. The occult Cnvm is a different pattern. It presents with a stippled hyperfluorescence, as you can see in this case. And when we see what the role, when we move to Icg, it has overcome some of the fundamental limitations of FFA because of the inability of FFA to visualize the choroidal vessels through ocular pigments in blood and the rapid leakage to the choriocapillaries. So because of this advantages, definitely Icg is an advantage and helps us in diseases like entities like RAP and PCV. So in classic CNVM, like we said, it's not really needed, but in occult, ideally, it should be done. Of course, now we have non-invasive modalities, so this can be discussed among the panel about how often it should be done. But I would recommend maybe non-responders where we suspect PCV, RAP, or patients with large subretinal hemorrhage where the lesions may not be seen otherwise. These are some cases where we do even now do Icg angiography. This is the most useful part of it. You can see the polyps beautifully on the Icg angiography. And these are some of the clinical features which will make you suspect the polyps. And this is the Icg done for it. When you have polyps, you can see them typically in the early phase, and in the late phase, they generally fade away, as you can see in this picture. And it is not meant, of course, to replace FFA. The Icg and FFA normally are done simultaneously, especially using the Heidelberg system. So it provides a complementary information, and naturally multimodal imaging and synergy is the best part. Of course, it is time consuming and costly. So that is a drawback, which is why the newer invasive modalities are more in vogue now. And these are some of them. Basically, first is autofluorescence, which gives us something about the physiological imaging for the RP status. We have hyper and hypo AF patterns, which you can see. And you can use either a camera, a flash system, or SLO-based system. What are the use in AMD? It defines the RP status, follows up during the treatment of CNVM, and the geographic atrophy. So an interesting finding is that in these areas where there's atrophy in the middle, the bright areas which are hyper autofluorescence show where it is going to progress. So these are hallmarkers or benchmark where this atrophy is probably going to increase. So this is the way we need. It's extremely important for following up these patients because of this. OCT, of course, is extremely important. And I think this is probably the most commonly used imaging modality now by everyone. So how does it help us? It helps us to study the natural course and lesion characteristic. It's a diagnostic adjunct. It helps to track the disease progression and the response to therapy. So let's see in some cases where OCT has really helped us. So this is a 69-year-old lady. So basically, this is also very important for her because we're also discussing this with general ophthalmologists, etc. Message here is that if cataract does not explain vision, please investigate. So basically, she had a similar cataract, but if you just see the color photo and just examine this patient clinically, you would see there is some macular degeneration, but it looks almost similar in both the eyes. Fortunately, the cataract surgeon got an OCT done, and you can see this patient has a CNVM with fluid. So it's very important that these are patients should be investigated because you can land yourself in a soup, and a screening tool like a OCT is really helpful when the cataract does not explain the loss of vision in these cases. So these are some examples where we can see these bumpy drusen. You can see a serous PED and a fibrovascular PED. Let's just see the characteristics in more detail. A classic CNVM, which is above the RP choriocapillaris layer, which is seen in a fusiform kind of a spindle-shaped layer, and you can see the corresponding FFA below. Occult Cnvm is more difficult to depict. It is ill-defined area of irregular thickening or fragmentation of RP choriocapillaris layer, or you can just have a PED with SRF. Hemorrhagic PED is present with moderate backscatter underneath with shadowing of the underlying choroidal layer because the blood itself is causing shadowing of the underlying choroidal layers. And in a fibrovascular PED, you have moderate backscatter underneath. So you can see this, some of the tissue is seen, but it's not very clear. That is totally unlike the serous PED where there's an optically clear space underneath. So that's well to talk about this, but where is it really useful? So this is an excellent article in JAMA Ophthalmology, which showed high sensitivity and specificity just by using OCT and a color photo for diagnosing PCV. So they found that signs like a sharply peaked PED, what we call a thumb-shaped PED. So this is a thumb-shaped PED, notched or multilobulated PED, or a hyperreflective ring. So these are the things which are under the PED. These were very, very sensitive and specific for detecting PCV in these cases. So this is a way they've kind of said that they're trying to see how we can standardize OCT and the fundus photo, and we don't need to do any invasive test in these cases. Of course, ICG remains the gold standard, but these are very, very good clues which you're getting just with these modalities. So let's see a few cases. This is the thumb-shaped PED, and this is which is a branching vascular network. And it is even seen here, when we have this branching network, we can see the double layer sign, which is seen, and the thumb-shaped PED, which suggests of PCV. And another case with a hemorrhagic PED, which is suggestive of polypoidal choroidal vasculopathy. What are biomarkers? So biomarkers, and what is the need for these in AMD? So when we talk about OCT, it's important to know about some of these biomarkers. These are naturally occurring characteristics by which a particular disease process can be identified, and they may help us to guide individualized retreatment decisions. So let us see a few of them. So common biomarkers in wet AMD, because this is the topic of the day, is the intra-retinal fluid. You can see in this beautiful article by Professor Ursula Schmidt's group that this is the SRF, which is blue, which is supposed to be a good prognostic matter. It's not really blue. I think it's more like a purple. The PED, which is which is dark red, which is seen underneath, and the hyperreflective foci, which are seen in green color, sorry, in yellow color. But the intraretinal fluid, which is seen in red color, is supposed to be a poor prognostic marker. So there's a whole long list. We'll not go into the details of these, but just highlight a few of them, which we've kind of highlighted. So the hyperreflective foci are particularly adjacent to the fluid lesions, and they are a risk factor for progression and advancement of disease. They also can be an early sign of type 3 or RAP neovascularization. And even the presence of IRC, PED, and SRF is associated with the hyperreflective foci. And that's why they are supposed to be a sign of a risk of progression. Another very important entity to be aware of is something called ORT, or outer retinal tuberculations. So these may be misdiagnosed as intraretinal or subretinal fluid, but this indicates the chronicity of the diseases, and they may be a sign that we can stop the treatment in these patients. SREM or subreflective retinal hyperreflective material normally associated with active CNV lesion, including subretinal hemorrhage, lipid or fluid, and it can be a predictive factor for non-responders. So these are basically the biomarkers, and we've seen these are going to have some prognostic value. We move on to OCTA. Why do we need OCTA? It gives us a 3D resolution, and the best part is it is depth encoded. So without a dye, we are getting to know the vasculature, and we are getting to know it layer by layer. It's especially useful for the type 1 CNV. You can see how beautifully the type 1 CNVMs are seen on OCTA. You actually see exactly what you're dealing with rather than just a fuzzy hyperfluorescence, and it helps us to assess the response to therapy. So there are a lot of articles. Please use your imagination. There's this Medusa head, sea fan, prune tree, etc. So these are the patterns which have been described, and these are some of the commonly seen patterns in the patients. And they have found that there's a lot of correspondence in patients between the CNV identified on OCTA and that on conventional multimodal imaging. So back to PCV. So basically PCV was an entity where it was found that there was a lot of discussion on Octa not being very useful. And in fact, I've shown the humble OCT also to be very useful. But with a little bit of time spent, there are some of the cases where we find that we see beautiful things like the BVN nicely on using OCTA. And basically what we found is the ICGA shows the polyps much better, but the BVN, the branching vascular network, is seen very well on the OCTA. So this is a patient, we can see the pre-therapy, the BVN and the polyps, and on the structural OCT, you can see the raised lesion, the flow in the polyps also. And after therapy, you can see it is resolved quite well. Multimodal imaging is, of course, important now that we've studied all those imaging modalities. So this is one of the cases which always perplexes us when we have the CSR kind of cases getting a CNVM. And we were always puzzled as to how to treat these patients and whether there's actually a CNVM or not. But now when we do a OCTA, the CNVM becomes clear to see. So I think that is really, really helpful in these cases. Another patient is when there's an intraretinal hemorrhage seen with a CNVM, we must suspect type 3 or RAP. And this is the neovascularization in the form of a retinal anastomosis. And you can see the hotspot on very nicely on the ICG. And you can see the intraretinal hyperreflective tissue, and the connection on the structural OCT. And this is how it correlates to the anatomy. So can there be a choroidal neovascular membrane in non-exudative CNV? So this is a very, very pivotal work by Dr. Phil Rosenfield and his colleagues who studied 11 eyes with asymptomatic intermediate non-exudative AMD. And these were basically fellow eyes. And the ICG showed a plaque in 3 eyes with no evidence of the CNVM on FFA or OCT. And what is very interesting is the swept source OCTA showed blood flow in cases of these presumed drusen, and the blood flow was resembling this. You can see beautifully this is highlighted in a different color, this pink color CNVM. So the point now is whether should these be treated or not. So there's a lot of debate going on about this question currently. Could they be precursors of more aggressive form, warrant a closer follow-up? Or could they be providing nutritional support for the overlying RP and photoreceptors? So that's something which can be discussed and debated. To conclude, these FFA, ICG, OCT are extremely important for diagnosis and managing neovascular AMD. The multimodal imaging approach is the way forward. Clinical exam is still important, and OCTA, of course, has a lot of applications in the future. Thank you.
That was great, Darius. You finished half a minute before your time. And you're muted, you know. Yeah, so.
Thank you, sir. Thank you. Welcome, sir.
I'm sorry.
I think you were in other session, so I had to.
No, I didn't have another session. My net suddenly conked off, and it took me a few minutes to settle it. So that is how it got delayed.
Sorry, the sequence has been disturbed.
No, it's fine. Thanks for taking over. And
so now I think we can invite Dr. Dinesh Talwar, a renowned retinal surgeon from New Delhi, former faculty professor at RP Center, with vast experience in treating all sorts of retinal disease, to present his talk.
Thank you, Darius. Can you see my screen?
Yes, so.
But yes, it's not on full mode, I think.
Yeah, I just wait. Okay. Yeah. So, well, we thought we'd take an overview of everything and then come to the individual issues. But Darius has done a great job of starting on time, and that's critical over here. This is my disclaimer and my financial disclosure. Now, we all know that ARMD or AMD is a degenerative disorder of the macula, affecting older adults more than 55 years of age, and the vision impairment occurs in the later stages of the disease. If you look at this epidemiology, what is very evident is that most of the patients with late AMD includes the ones with CNVM, with geographic atrophy, these are all, they start off in the age group at 50, increases steadily from 50 to 60, and then by the time they reach 70 or 80, the incidence goes up significantly higher. A note here, I think in our own context, we seem to have these changes a little earlier, maybe a decade earlier than what we see in the West. So we can expect to see CNVMs in the 60s also, and fairly commonly. Now, what are the stages of AMD? Again, it's not one stage. You can have the stage of no AMD, in which there are no drusen or very few small dot-like drusen, also sometimes called pulloids. Then you have early ARMD. This is the arid stage category 2, where there are multiple small drusen or a few intermediate-sized drusen, very mild RP abnormalities. And then comes those which is intermediate AMD, which we call that's category 3, where there are numerous intermediate sized drusen or more than one large drusen, or there is early geographic atrophy setting. Advanced ARMD is the ones which we are most bothered about, where it's dry ARMD is geographic atrophy, and that we really don't have any treatments at the moment. But if it's neovascular AMD, there's the presence of a CNV with either a serous or a hemorrhagic detachment, which that is just showed you, along with some retinal hard exudates, fibrovascular proliferation, or finally it reaches a stage of scar. These are all the advanced stages of ARMD. How do these patients present? When the patient comes to you and says, look, I'm seeing this black spot, and I move my eye, the black spot moves with the movement of the eye. This is a scotoma. This is not a floater. This scotoma is a very specific sign of AMD. In fact, if you just look at it, this is what it would look like. This is a normal image. Now, if you had an early new leaking AMD, you have a black spot over here. And this is the problem with this disease. The poor fellow can't see the central area that he wants to see. He wants to see the face, he can't see the face. He wants to read something, he can't see. He can see the things on the side. So he never goes completely blind, but he can't see what he wants to see. And then when time goes on, finally he's left with a white area, from which is a missing area in his field, which is in the center of the field. It could appear like this if it was for distance. If you were looking for distance, it could be a patch like this. The other important thing, and which is very specific, is distorted vision or metamorphopsia. So this is not the periphery of the vision, this is the central vision. And because of this, he has difficulty in reading detail. So if you ask him to look at a window, he says, steady the plate. It's not straight. Look at this golf club, to him it's appearing like this. Obviously, this is not the way the golf club is looking, is actually there. And on the Amsler's grid, he can pick up this kind of distortion. The first thing is you need to distinguish dry from wet ARMD. Dry ARMD is the more common form, as you saw in that graph. 80 to 90% of cases, only 10% are neovascular. And the dry ARMD is insidious, goes up to geographic atrophy, very slow vision loss, and accounts for only 10 to 20% of vision loss due to AMD. Neovascular AMD is the most scary thing, causes rapid, severe vision loss, and the vision loss is fairly progressive. It leads to, and this is due to choroidal neovascularization or a occult Cnvm because of a pigment epithelial detachment. And this accounts for 80 to 90% of the vision loss you see in this disease. And this is treatable. This is the good thing about it. Now this is treatable. What you see here are two forms of dry AMD. You see this, you can see the very small drusen, you can see the intermediate sized drusen, and then you can see the large drusen also. And these are, this is like a drusenoid RPED. This is large drusenoid. Here you see geographic atrophy on the other side. You can see a patch of geographic atrophy just reaching up to the center. So these are forms of dry AMD. Wet AMD on the other end, there are two parts to it. One is where is the lesion located? Extrafoveal lesion, more than 200 micron from the foveal center. In today's day, I say if it was say 1 disc diameter from the foveal center, you could easily treat it by laser. So this is very important to know where is the lesion. But subfoveal lesions, that is 1 to 199 micron from the foveal center, or those which are juxtafoveal or subfoveal lesions, can only be managed by treatments which do not damage the macular or the foveal photoreceptors. Now, how do they present on fluorescent angiography? If you look at it, classic CNV will present like this. Clinically, it looks like a yellowish gray lesion, but early phase of the angiogram could show you the network of vessels and hyperfluorescence, which is quite intense, and that becomes much more intense over time and becomes a blurred margin. This is classic CNVM. The other form is the occult Cnvm, which has two forms. One is called the late leakage from an unknown source. Now you see in the early phase there is virtually no hyperfluorescence, and in the late phase the whole area fluoresces. So this is late leakage from an unknown source. The other form of an occult Cnvm is an RPE detachment, where the filling occurs in the early phase, and the late phase, the margins remain equally distinct, but the intensity of the fluorescence increases. Now, this is how we used to diagnose on fluorescent angiography. Nowadays, we do it on OCT, and Darius has shown you part of that. So classic lesions are the ones which are above the RPE. Occult are the ones which arise below the RPE, and PCV, polypoidal choroidal vasculopathy, is a variant of that. And finally, you have those which are rising in the substance and going downwards, that is retinal angiometers proliferation. So let's see all three. This is type 1, where you can see an RPED, and this is type 2, where you can see that the lesion is above the RPE, and type 3, it's a rising in the retinal substance going downwards into this, creating an RPED, or just very early, just a rising in the RPE, in the retinal substance, and not yet gone down much. The important thing is that both classic CNVM and occult CNVM can cause vision loss, and that happens in a large number of patients within 2 years. The classic CNVM is more rapidly progressive as compared to occult CNVMs, but finally they will also result in a loss of vision. Now, pathologically, basically, drusen are deposits under the RPE. They're between the RPE and the Brooks membrane, and this is what you see over here in this location. And finally, these drusen disrupt the overlying function of the RPE, and then the photoreceptors get affected. In neovascular AMDs, you get a choroidal neovascularization, which is an abnormal growth of new vessels starting from these choroidal vessels, then disrupting the RPE, and then they either bleed, and you get a bleed under the retina, in the area of the photoreceptors, or you could have exudation of fluid. And this is what disrupts the vision after that. And finally, scarring occurs, and you have permanent loss of vision. Now, if you'll notice, the vascular endothelial growth factor is central to the pathogenesis of this disease process. So when you have this eye which is aging, it's had lots of UV exposure, it's a thickening of the Brooks membrane occurs, choriocapillaries are getting thinned over time, and there's oxidative stress which is occurring over time because of age. And finally, you have these drusen formation, ischemia of the RP, and then finally, because of release of VEGF, because of the ischemia, you have angiogenesis and CNV formation. So let's see, once you have the VEGF formation, what happens? The VEGF formation occurs, the endothelial cells of the capillaries, they get activated. When they get activated, they in association to that start causing basement membrane degradation, allows endothelial cell proliferation and migration, and finally these endothelial tubes form, and then the neovascularization occurs with remodeling. And this is how the whole process of a CNVM occurs. The VEGFs are of various types. The ones which concern us most is VEGF-A, which has at least 5 major subtypes, the 111, 121, 45, 189, 206, but the most important one in this is 165. So this is the one which causes the angiogenesis, which disturbs the retina and which we are bothered about. Now, it's not just the VEGF. The fact is the VEGF has its action by going on to VEGF receptors. And here you have VEGF-R1 and VEGF-R2. These are 2 different receptors which play a major role in the development of neovascularization. So you can either attack the VEGF directly or you can attack the receptors. So how does management of neovascular AMD occur? Now, if you go sequentially till 1980, we had no treatments. In 80s, the thermal laser became evident as a useful tool, initially used for extrafoveal lesions, found to be very useful. Then we tried to extend it to juxtafoveal lesions. You used to be left with a scotoma. And finally, people have, God forbid, never to try that again. But people have tried it for subfoveal lesions. We actually tried it for subfoveal lesions. We used to tell him, Abhi to you're going to lose 6 lines of vision, you're going to go blind, but you'll be much better off 2 years hence. A very, very stupid way of handling things. Fortunately, by 2000, we got photodynamic therapy. Now we used to say, well, you're not going to go blind immediately. This disease can now be managed. You'll go blind over the next few years. So you'll go blind much slower. But it's only from 2005 onwards that a revolution occurred in the form of anti-VEGF therapies, when now we say, hey, wait a minute, we can hold you, we can help you, we can improve you. And this is what is the current management. The first approved therapy was ranibizumab. And this came from 2 trials, the Anchor study, which was on classic CNVMs. And you can see, if you compare PDT, is slowly going down. And with Anchor's ranibizumab, now you say, hey, you're going to improve. And you have a 10-letter improvement over the next 2 years. So this is what revolution occurred because of ranibizumab. And the same thing happened in occult CNVMs. You can see the same kind of improvement, though not as dramatic, occurred with the ranibizumab in the occult CNVMs also. Few years later, we got aflibercept, which, whereas ranibizumab was a fragment of the FAB fragment, the aflibercept was, so it's an anti-VEGF drug. Aflibercept is a VEGF trap. It traps the VEGF with a decoy receptor. And the VIEW trial showed that, yes, aflibercept works at least as well as ranibizumab. And so it became the second important drug for management of AMD. Now, while the treatments were, or while the drug was discovered, then the question was how to use it. Initially in these studies, it was used monthly in the Marina and Anchor. Then we tried to use it quarterly. That found not good enough in many of the trials. Then people tried PRN treatments, and then finally came up to treat and extend. In the meantime, VIEW study for aflibercept tried it bi-monthly and found that works. So the evolution of the way of giving the treatment has also been occurring in this time. Still, despite all this, there are certain unmet needs. And what are our unmet needs? The fact is, we want to reduce the treatment burden for the patient. We want to improve the safety for the patient. We want to give a more longer or sustained delivery. And we want to see if we can have newer mechanisms of action which will work better. So all these efforts are going on. And one thing we realize is that the basic crux of this whole thing is insufficient fluid resolution. If the fluid was resolving well, all these other problems would also go. And so what is it that we want to do? We want to resolve the retinal fluid, which is the overall treatment objective in neovascular AMD. This fluid, which is in the intraretinal spaces, in the subretinal spaces, in the subretinal space, the sub-RP space, this is an early sign of disease, active disease. And if this can be managed, the patient can be helped. If this continues for a long time, vision loss will occur. So this is the crux of the whole problem. All our strategies are designed to minimize the fluid, remove it if we can. We can't remove it, then the next best thing is to minimize it. So this is what we are trying to do. So far, we have two drugs, ranibizumab and aflibercept, and it's possible that a next generation anti-VEGF, brolucizumab, which is now in the market, but is still has certain issues which are being dealt with, will provide us the next alternative. So let's see how things go, and I expect the other speakers to give you more details of all these things that I have pointed out, and I'm now looking forward to that. So to summarize, we have a degenerative disease which results in loss of central vision, doesn't make you totally blind, characterized by leakage of blood and fluid, driven by VEGF. So anti-VEGF therapy is the current standard of care, and visual acuity will decline in the long term. Even now, over a period of 7 to 10 years, we will have decline in vision in some patients. So we still need better drugs. The holy grail for us is a long-acting, safe anti-VEGF drug, which is effective against all forms of retinal fluid, which is because this fluid is a basic sign of activity. And if we can do that, we have conquered this disease. Thank you very much, ladies and gentlemen.
Thank you, sir, for wonderful lecture. So we'll move on to the next lecture by Dr. Parveen Sen, ma'am. Parveen Sen is a senior consultant at Shankar Nethalaya. Her main area of interest is pediatric retinal surgery, retinal imaging, macular disorders, especially polypoidal choroidal vasculopathy, and also she's heading a genetic disorder department in Shankar Nethalaya. So pleasure to have you, ma'am. Over to you.
Good morning, everyone, and it's a pleasure to be a part of this workshop, especially with the eminent speakers with me. Dr. Dinesh Talwar has made my job very easy with his detailed talk on the classification and pathogenesis of AMD. So I will next take you to the patient journey as to what happens once you have seen a patient in your clinic who has AMD. So how do you proceed further? So first question that probably we would like to answer is that, is this neovascular AMD that you are dealing with? Most important, as mentioned by Dr. Talwar also, are the symptoms. The patient comes to you with this characteristic symptoms of scotoma and metamorphopsia. In fact, you cannot miss the metamorphopsia. This is one of the earliest symptoms, and not only the symptom of disease, but symptom of activity. You will see that as long as metamorphopsia persists, usually the disease is active. In addition to it, other family history and systemic history will also be useful. So it is best to elicit also at this point of time. A comprehensive eye examination at the first visit is a must. A stereo biomicroscopic examination can help you, at least you know what you are identify what you are looking at, and probably it will give you some idea as to which investigation we would like to do. And Dr. Drais has already mentioned us the whole long list of investigation which is available for these patients. But after your examination, you can choose which one will be most apt. You may not always need to do all of them. For my patients, what works well for me is that fundus examination, a fundus photograph at baseline, and of course, OCT. OCT is necessary at baseline, and these are the few typical features of AMD which will be seen on OCT. You could have fluid in the subretinal space, or you could have these serous PEDs, or you could have fibrovascular PED, as was explained by my previous two speakers as well. All these are features of neovascular AMD. Third question is the disease active? Because you could have patients who have scars due to AMD, so you don't go ahead and treat them, or you could have intermediate AMD or early AMD as was discussed by the previous speaker. So you want to know whether this disease, which is AMD, does it need treatment or not. Most important is presenting BCVA. So if there is a recent loss of at least more than 5 letters, you know that this is an active disease that we are looking at. New subretinal hemorrhage and presence of fluid on OCT that we'll see on the subsequent slides. Only one thing that I would like to highlight, that though a drop in vision is the most classic symptom of active disease, but you could have patients who have vision as poor as 3/60, and they have large membranes which have been there for a long time. You need to be sure that this is a recent progression of diseases there before you go ahead and treat the large lesions. On the other extreme, I would mention that even if the patient has 6/6 vision, you would definitely treat if there is an active neovascularization. So most important biomarker of disease is fluid, and this would probably be discussed by subsequent speakers as well. But you could have fluid in almost all 3 compartments. As was seen here in this slide, you have fluid in between the neurosensory retina and the pigment epithelial detachment, or you have it below the pigment epithelial detachment, or you have intra-retinal fluid, which is within the neurosensory retinal layers or within the inner retina. So subretinal fluid is the most common, and this is usually seen along with the type 1 CNV, which Dr. Dinesh explained earlier, which has its seat below the RPE, and the intraretinal fluid can be seen in all forms, but usually is a presenting feature in cases of type 2 or type 3. A type 2 membrane, just to revise, is above the retinal pigment epithelium, and type 3 arises within the retinal space and then goes down. Just a thing to remember, that sometimes you can have these large cysts which can be present over these disciform scars. So these large cysts vis-a-vis IRF, which are small tiny cysts within the inner retina, they may not always represent activity, and these could be signs of a degenerative retinal cyst. Fourth point, look at the size of lesion. If it's again a very large lesion, more than 12 disc diameter, think about therapy, because it's a long-term therapy. The visual outcome may not be great, but in the evidence of a recent disease progress, you may still think of treating. Associated risk factors, especially smoking, which you have to encourage the patient to stop, and history of cardiac disease, history of stroke, because minimal increase in risk of stroke and cardiac disease is seen in anti-VEGF patients who are taking anti-VEGF for a long time, but this should not warrant against the treatment. You rather can be in consultation with the cardiologist before you initiate any therapy. Next step for me is the classifying the age-related macular degeneration, the type of CNV, whether it's type 1, type 2, type 3, or most importantly, PCV. So this, as I mentioned, type 1 is below the RPE, type 2 is above, and type 3 within the retinal surface, inner retinal layers, and grows downwards. The importance of these things, whether it's type 1 or type 2 or type 3, though the treatment is still going to be in form of anti-VEGF injections, importance is that if you have a type 1, usually the patient presents with good visual acuity, and they may maintain visual acuity for a long period of time if treated well. But if not treated well, they lose these visual gains over a long period of time. And collapse of type 1 CNV can cause geographic atrophy. Type 2 are more prone to form disciform scars, and type 3 are actually highly responsive to anti-VEGF therapy. But again, you may limit the number of anti-VEGF injections in these eyes because increased risk of GA has been attributed to type 3 lesions. And if you see PCV, you could consider PDT and not just a monotherapy with anti-VEGF. So this, again, as I just mentioned, whether you're going to do monotherapy or combination, in cases of extrafoveal thermal laser, as was told by the previous speaker, and PDT for subfoveal lesions, only when you see patients with PCV. Usually, steroids do not form a mainstay of therapy in neovascular AMD, but certain specific conditions at all you could consider. Anti-VEGF is the monotherapy, is the gold standard now in this era for neovascular AMD. And it has been shown to preserve vision, to improve vision, and maintain long-term visual gains. The next is treatment protocol. So ideal would be you give it to do the treatment once and you're over and done with, but that doesn't happen. So you have a treatment protocol. You give 3 monthly injections in type 1, type 2, type 3, most of the times, though of course at 1 month follow-up you evaluate the patient. And if you have no response, then you think whether you're going to continue it or you need to switch it. And if you have the lesion is absolutely dry, you may consider either observe and extend or treat and extend. And if the response is there but not completely dry, you can go towards treat and extend treatment. So despite all these things, the lessons learned are that most of the patients do need treat and extend, and they should not give up just after a few injections. So this is where the patient counseling is most important, that you should counsel the patient in the first sitting itself that this is not a single time treatment. Unfortunately, though subfoveal CNV because of neovascular AMD is amongst the top diseases which affects the quality of life in patients, but the amount of know-how or knowledge is very minimal. Regular screening protocols for patients more than 50 years of age are not present, and it comes as a bolt from the blue when the patient suddenly knows that he has this problem, and then you have to tell the prognosis, the potential value, the kind of treatment, monthly follow-ups, extended follow-up. All this has to be explained to the patient, and lifestyle changes also. And not only the follow-up, but to tell this about the symptoms which can cause a drastic decrease in vision, especially when we are giving intravitreal injections, which is an invasive form of treatment. So follow-up is also equally important. Again, record visual acuity at every time, do a stereoscopic examination, and then you do almost OCT may be necessary every month. FFA only if PDT has been done, then you may consider once in 3 months. And if you have done thermal laser, usually best time to see is about 2 to 4 weeks, whether your thermal laser is adequate or not. And once you have initiated the response, how do you know whether the patient is responding also or not? So you could have functional parameters, morphological parameters, or a combination of the two. So usually what I look in the functional is the response at 1 month. You can also see the response at the end of 3 months of 3 loading injections, which means a response at 4 months. So at 1 month, if you see that there is a more than 5 letter gain from baseline, which is a very good response. If it is 0 to 5 letter improvement, which means it is a partial response, or if there is no change, then it may be a poor response. And non-responses, as I said, that you could have a drop in visual acuity actually. So usually, though this can give you some idea at 1 month, but that does not mean that you should stop the treatment if it is not responding. 3 loading injections are generally advised. And then you look at again, a functional response at 4 months with a similar criteria. Anatomical or morphological responses are seen at 4 months, and you could have patients who initially respond well, but then do not have a good response, or you could have patients who initially do not respond, but may gain 4 to 12 months later, which is a late responder. So it is definitely worthwhile to keep the patients on these monthly injections for at least 3 to 4 or up to 6 months. So morphological response is seen on OCT. Good response is reduction in fluid by up to 75%. And if you see that there is a less than 75% response, then it may not be a very good response. And if there is worsening, then we call it a non-responder. So primary failure is judged usually at 1 month after the 3rd injection, and secondary failure is anytime after 6 injections. And recalcitrant CNV is something that after 6 intravitreal injections also, the patient does not respond. Only then you are justified in calling it a recalcitrant CNV, and that too 6 monthly injections. So a proper protocol, if it has been followed for 6 months, then only if the CNV does not respond, you label it as a recalcitrant CNV. Once you see that there is inadequate response, I think this is the time to reevaluate and usually look for if any other cause is there. And most commonly, it is sometimes PCV, in which you need ICG to establish your diagnosis. Other common causes which could masquerade a neovascular AMD include CNV because of CSCR, vitelliform disease, post-uveitic CNV, or MACTEL. So what happens if you have inadequate response at 4 months? Do I switch? Yes, at a primary failure at 4 months, you could consider switching or continuing with the same anti-VEGF after 6 months, after which again, you can take a call whether you need to switch the anti-VEGF or not. Another term which is usually used is called the treatment pause. Treatment-free period is usually given when after a long time you feel that the patient is still not showing too much of improvement. You stop the anti-VEGF for a while and see that after stopping, is the disease worsening? So if the disease is worsening, you know at least some effect the anti-VEGF was having. So you continue with the anti-VEGF. But if after stopping the drug also there is no worsening as well, then obviously in the recent Retina Journal in 2020, this lesion has been described as a futile lesion, in which case you can consider cessation of therapy. So aim of treatment is not only to give the injection to improve vision and stabilize and help the patient maintain these improved visions for a long period of time and individualize these treatment regimens. In patients who are not able to regain 100% of their vision, especially in bilateral AMD cases, visual rehabilitation plays a very important role, and this definitely must be offered to the patient. Follow-up of the fellow eye is extremely important. You could see this ARED score and you realize that even the drusen or presence of a CNV on the other eye can increase the risk of development of advanced AMD in the fellow eye as well. And you may have to offer the patient regular monitoring as well as AREDs to supplements. In spite of very good treatment, we still have many unmet needs. The most important is the need for multiple visits, multiple OCTs, and we need definitely long-term formulation, sustained delivery devices, and topical or oral therapy if could be devised. The need for this invasive treatments every month can be reduced. For me, I think the home OCT monitoring can be very handy, especially in this COVID era, that you could not, you can reduce the number of visits that the patient comes. And if combined with deep learning, you could have the machine giving you the answer whether you need to go to the office or to the hospital for the injection or not. So with that, I end my presentation for now, and we go on to the next one.
Thank you, ma'am. Next, we'll move on to the next lecture by Dr. George Monayat. He's a senior consultant and professor at Arvindaya Hospital, Coimbatore. He has a special interest in polypoidal choroidal vasculopathy and done a lot of research in PCV condition. Over to you, Dr. George.
Are my slides visible?
Yes.
Yeah. Okay, so after a beautiful overview by Dr. Talwar and a lot of imaging and extensively covered by Dr. Parveen, my job is just to stick to the current treatment protocols and the molecules that we have, because most of the things and how the patients are followed up and imaging and other biomarkers, everything has been discussed so well. It becomes simple. My job becomes simple. So let me add something to the treatment and follow-up of these patients. So as already mentioned, anti-VEGF therapies have revolutionized actually the treatment of neovascular AMD and reduced the AMD-related blindness we have seen. But what is the current challenge is that firstly, this disease is a long-term disease as seen by 5 years of CAT study results and 7-UP study. The challenge is to maintain this efficacy, but to reduce the number of injections and follow-ups, which is currently the main challenge that doctors and patients both face at this time. So the treatment burden is not just the cost of injections over 5 or 7 years, but for old age people to travel over long time and multiple visits with all the old age related comorbidities. This is the reason why after the first 2 years or 3 years, most of the patients we have seen in practice that they drop out from the treatment and come with a drop in vision, which is irreversible. So it is important for physician as well as the patient to understand the disease nature and educate the patient accordingly. And that is the most key in success of this treatment. So coming to the regimens that we have, we know already mentioned also that monthly regimens have the best efficacy, but it is totally impractical. So we need an individualized treatment regime. So the commonly now popular one is PRN regime and treat and extend. So PRN regime is widely followed in India, where patient is injected only when there is some fluid at the macula or drop in vision. Whereas the treat and extend is more individualized, patient receives a fewer number of injections and fewer visits to the clinic. So let us look at what this is actually. So Trend was a major study that compared treat and extend versus monthly injections and showed that visual acuity improvement was same compared to monthly injections with fewer visits and injections of ranibizumab in treat and extend regime. And also a large real-world studies of meta-analysis of around 26,000 patients showed that compared to treat and extend, the PRN regime has the limitations of increased visits, where we have fewer injections, but the monitoring visits remains monthly. And so too many visits and less visual acuity gain compared to treat and extend regime in PRN. Probably this is like a under treatment or suboptimal treatment, which is followed in many places. So what is this treat and extend regime that we are talking? In the SRS survey, 75% of the retina specialists prefer treat and extend in neovascular AMD, unlike diabetic macular edema or vein occlusion. So here, this is nothing but monthly 3 loading doses. And once the macula is dry, extend the further visits. All visits are injection visits, and these visits are extended by 2 weekly or 4 weekly until once in 3 months injection. At any time, macular fluid or drop in vision, reduce the next further visits by 2 weekly or 4 weekly back to once in 6 weeks, depending on the disease activity. So let us look at a case example here, wherein patient with type 1 neovascular AMD, the initial 3 monthly loading doses were given. This is the 4th month visit. Patient is active. There is a sub-RP neovascularization, subretinal fluid is there. So patient gets an injection. So next, because it was aflibercept, the next visit was 2 monthly. So after 2 months, patient comes, still there is fluid under the macula, disease is active. So gets another injection at that time and still called after 2 months. So at this visit, the patient's macula is dry, but still in treat and extend, patient gets the injection and extended the next injection visit to from 2 months to 2.5 months. So at that time, an almost dry macula, bit of fluid. So at that time, still patient gets the injection and try to extend it to once in 3 months, as we just discussed now. But at that time, there is fluid here. So shorten the visit. So back to once in 2.5 months visit. So this is exactly what happens in treat and extend, and patient gets injections, but it is tapered according to the patient's need based on the visual acuity and OCT dryness or presence of subretinal hemorrhage. So why we need this regime is because if you look at, as already mentioned by previous speakers, that when you look at, this is the 5-year results after the initial monthly injection and super results with ranibizumab. But when we look at the 5-year results with PRN after the initial structured visit, it is back to baseline, -1 letter compared to the baseline. And also that we know in 7-Up study, which looks at PRN after the initial monthly anchor marina at the 7th year, when you look at active exudative disease was seen in 70% of the eyes, and 50% were undergoing anti-VEGF injections, PRN, and around 98% were having some sort of macular atrophy. So this is the significance why this happens. As we have, when you look at the sustained study over long-term results, this is a long-term results. These fluid fluctuations that happens with PRN, because you are waiting for the fluid to come to inject, and these fluid fluctuation, the vision that is lost by the fluid fluctuation after the injection do not regain completely. So when you look at 5 years or 6 years, there is a gradual decline in vision with this Prn regime, as you can see in this study. So now when we look at treat and extend protocol, the Moorfields protocol, they used aflibercept in this study. So they saw that the visual acuity is maintained at the end of 3 years. After the initial 8 injections, the subsequent years, the injection substantially comes down to 4 injections. And at the end of 3 years, the vision is maintained. When you look at the 6-year results, the range study, this was also with aflibercept. So they found that with treat and extend, it is seen that the visual acuity has not gone down below the baseline, but it is maintained with the regime that you follow. So now how to extend? So it is either minimum two monthly as per the Altair study, and maximum it can be extended to once in 4 months injection. So if there is we have a dry macula with no fluid, extend it as we saw in the case that we discussed. And if there is a new fluid and drop in vision, shorten the visits to a more frequent injection visit. And there's a subtle residual fluid less than 100 micron here and 200 micron in fluid study. They maintain the injection visit interval as it is. So this is how it is decided. And in newer anti-VEGFs like brolucizumab or aflibercept, it is seen that around 60% in aflibercept and around 80% in brolucizumab require a longer duration. You get a treatment-free intervals of more than 3 months with these newer drugs. So that is what Dr. Talwar was mentioning to about, that we need longer acting drugs. So that is one aspect. Another aspect, how we can avoid injection. To me, this protocol is very important. Not only treat and extend, treat, extend, and stop protocol, where initially it is only treat and extend. After the monthly injection, extend by 2 weekly or 4 weekly to once in 3 months injection. Once in 3 months injection, and if the macula is dry, patient still receives 2 more 3 monthly injections. That even if the macula dry, and stop the injection. So that is treat, extend, and stop. These patients, better than always on injection, stop the injections and see. And if the macula still remains, patient is put only on an observation, that is initially monthly observation and extended to once in 3 months observation. So this protocol is quite impressive, because after 8 years, it is seen that 35%, more than 1/3 of the patients had 15-letter gain, which is very important in a long-term study, which we have seen what happened in 7-UP and CAT study with PRN. So the long-term anti-VEGF efficacy, this study shows it improves or maintains the vision on a long term. So this also gives some clues to one of the protocols which we could take into practice. Also in Europe, this observe and plan regime also is quite shown important results, because after the initial monthly loading doses, patient is just observed to see when is the recurrence interval. For example, in this patient, 3 months the fluid has recurred. So next 3 injections are scheduled, only injection visits at a shorter duration, that is 2.5 months in this particular patient. And then the next evaluation visit is after 6 months to look at the disease activity. And then if it is exudative, then shorten intervals for the next 3 injections. So this also has shown that the number of injections were almost similar to treat and extend, but it dramatically reduced the number of monitoring visits to the patient. So hence fewer clinic visits than treat and extend regime. So lastly, to touch upon the fluid study results, because in this treat and extend protocol, fluid study said that if you have a subtle edema less than 200 microns, that is not resolving despite monthly treatment. So that is very important. Not that the fluid is good for macular health, but despite monthly injection, a subtle fluid, still we can extend the injections, and that would not cause an additional risk of vision loss after 2 years of study. So visual acuity improved despite failure to completely resolve the fluid all the visits over 2 years. So I would conclude saying that anti-VEGF treatment has evolved into treat and extend protocol now for good visual acuity gains with fewer injections and visits individualized to the patient. Prn regimes may have suboptimal visual outcomes and result in irreversible deterioration of vision on a long term that we see over 5 years or same. Because of this fluid fluctuation that happens, you wait for the fluid to recur to treat the patient. So newer, longer acting molecules that has been already mentioned here are promising efforts to reduce the treatment burden, not only to the patient, but to physicians and the crowded clinics if you are going to monitor them monthly. So thank you for your kind attention.
Okay, so we'll move on to the next talk by Dr. Sabyasachi Sengupta. He's a consultant ophthalmologist and retina surgeon, founder and director of Future Vision Eye Care and Research Center based in Mumbai. He's also founder and director of Sengupta Research Academy. Over to you, Dr. Sengupta.
Thank you so much, and a very good morning to everybody. I'm very happy to be part of this August group of speakers. So today I've been mandated with speaking about intravitreal injections, some tips and tricks. So I'll keep it short, and I'm happy that I'm not having to go into a lot of data and a lot of statistics, because it's quite difficult to present, and all the previous speakers have done a great job. So now that we know how to, when to give, in whom to give, how many to give, now it's sort of time to dive into how to actually do it. So I'll quickly discuss some tips and tricks how you can do it successfully. So I have no financial disclosures, and all these ideas are solely mine. So I think the overall outline that I thought I'll discuss with is how to counsel the patient, that is, convince the patient of the need for injections, and what will be lost if they don't take injections. Then a bit about sterilization, injecting in the OR itself. Then a little bit about loading the drug and some do's and don'ts during that. Then of course preparing the eye with disinfectants, etc. Then a bit about anesthesia and how to make it as painless as possible. And lastly, the actual injection procedure, which quadrant and how and other things. So we'll quickly look at these. The first thing is counseling. I think it's important to explain the pros and cons of therapy to patients, and we now already are aware of all those that go into decision making with Dr. Parveen and Dr. George have very nicely elucidated all of those. But I think it's important, sort of the crux of it is to get across to the patient that we are looking to stabilize vision, may or may not improve always. So the primary aim is to stabilize vision, and sort of the 1/3 rule is applicable especially for neovascular AMD, which has come out from the 7-UPS study that Dr. George was also mentioning, that about a third of the patients continue to lose vision whatever we do. A third of the patients actually maintain vision, and a third of the patients improve vision. So the earlier we begin and the more number of injections we do, the better the chances are that patient will be in the best third. And so I think that works a lot, and a lot of patients actually, do come around and agree to take the injections. And of course, the regimen, we need to explain to them right at the beginning that the treat and extend is the most favored amongst, most of us now. And, also, if not taking treatment, they should understand that vision loss is irreversible, because I think a lot of patients don't realize what it means to actually protect what they have. And everybody's looking at improvement, but it's also a very big deal to protect what you have. Like Dr. Talwar was also telling us that, a lot of patients will continue to lose vision even if they get treated. So it's a no-brainer that vision loss is going to happen, and it's going to be irreversible, especially when we talk about neovascular AMD, and not so much for diabetic retinopathy maybe. Then also a little bit about financial planning with patients, I think helps quite a bit. So the cost of injections, insurance coverages, which are now available by majority of insurance providers, especially when insurances have been renewed after October 2020. And there are some schemes from manufacturers where the cost of injections actually goes down. And of course, the total number of injections of patients need to plan for all these 5 or 6 or whatever that may be. So I think these things are important to get across while counseling. Then talking about sterilization, so I think it's imperative that we inject in the OR only and not in the OPD, like in the West. A lot of people do that, but so OR preparation has to be same as any other intraocular procedure. I think that is a very basic and minimum. And autoclaving can't also be neglected. So a full cycle autoclave to prepare your instruments, just like you would for any other cataract surgery or any other intraocular surgery, is also imperative to minimize risk of infections. Then the instruments needed for are relatively simple. So you need calipers to measure distance from the limbus. You need a speculum to keep the eye open. You need gauze and you need sterile buds, and that's about it. And the role of preoperative antibiotics, I think it's not recommended anymore, and there is no evidence that the risk of endophthalmitis reduces. So preoperative antibiotics are not really recommended. Then I think it's important to load the drug before taking the patient inside the OR. So I think we need to confirm the drug, that we are giving the drug that was promised to the patient, the batch number, its expiry date, the temperature that was maintained. So these are some non-negotiables that we should do. So I have a checklist that I go through. Then the instruments that you should have with you. So a speculum and caliper must be there. The syringe, the needle to draw the drug from the vial, that is a much thicker needle, about 18 gauge, and the injection to inject the drug, that is a 30 gauge needle. So all of this must be in front of you. Then load the injection into the syringe, so measure exactly 0.05 ml that is to be injected, and attach the needle to be used, get rid of all the air bubbles and all of that. And then think about whether you want to use a microscope or an indirect ophthalmoscope, and see that those are ready before the patient walks in. Unless we do these, I have seen a lot of people running helter skelter. Oh, this is not there and that is not there, and it can sometimes be embarrassing. So we were looking at all of this. We've already talked about counseling, sterilization, and loading the drug. Let's see about preparing the eye. So povidone iodine is really the cornerstone of preparing the eye, so that there's umpteen evidence that this reduces risk of infections, not only in intravitreal procedures but in all intraocular surgeries. So 2 applications of at least 5 minutes apart, and there needs to be sufficient contact time. So we can't really instill the drop and immediately take the patient into the OR. So a contact time of about 8 to 10 minutes is recommended. Then anesthetic drops at the same time when patient is being prepared. Again, no antibiotics are needed at this time because povidone is doing the job for us. Doctors, of course, wear masks, and there is a bit of controversy about whether patients should be wearing their masks. And there are a couple of papers recently in Retina which have shown increased risk of endophthalmitis if patients are also wearing their masks. So in COVID times, this is something that we need to also think about. So I prefer, I don't prefer patients wearing the mask inside the OR, but it's important that they should not speak at all, so that there is no release of any aerosols. A little bit about the anesthetic, we need to really, make it as painless as we can. So what I also do is I take the buds and I, dip them into, the proparacaine solution, at least 3 or 4 drops onto the bud, and I actually massage the area of the sclera with gentle pressure so that the conjunctiva is blanched in that area. And then I go in circular motions for about 3 or 4 times, so that, that I think really numbs the area even more than just the topical installations. And I think this also helps. When you're looking to inject something like Ozurdex or something which has a larger needle, subconjunctival lignocaine definitely helps. But for routine 30 gauge injections, this is unnecessary. Then the injection procedure, of course, itself, speculum directly, and there is no need for any drape as such. This is a quick animation showing the procedure. We'll discuss some nitty-gritties about this. So the points that we need to consider is which quadrant you want to inject in. So if you're a right-handed surgeon, the infero-temporal quadrant, and if you're a left-handed surgeon, the infero-nasal quadrant in the left eye of the patient are relatively easy for you to access. It's important to be careful of, in certain eyes which have undergone previous conjunctival surgeries, for example, plaque brachytherapy, which makes, and a radiation retinopathy. If you're injecting, that conjunctiva is really sort of engorged, and a lot of the times it's not close to the limbus and can lead to a lot of huge subconjunctival hemorrhages. Similarly, patients who've undergone, say, previous scleral buckling and other things. So just be careful that, these are also taken care of. Then the distance from the limbus really depends upon the phakic status of the patient. About 3 millimeters from the limbus is good enough for pseudophakic patients. 3.5 to 4 millimeters is good enough for phakic patients. If you're doing ROP, it's about 1 millimeters from the limbus. Then think about the needle direction. we use the 30 gauge needle almost all the time now, and I prefer an oblique entry, like we do it for our cannulas during surgery. And once they are inside, you turn the needle towards the optic nerve head and then inject. So this is what you can also go straight into the sclera without this oblique entry. But then I've observed that there is a little bit of egress of the vitreous, and sometimes, especially in vitrectomized eyes, it can undergo hypotony suddenly. So this oblique entry, I think, helps. And lastly, think about whether you want to use the operating microscope and an indirect ophthalmoscope. So I think anterior segment surgeons may be more comfortable with using the microscope, but I think most retina specialists, inject by wearing the indirect ophthalmoscope, like I do, so that you can actually take a look inside immediately as you inject. So these are some of the points that you want to consider while you are actually injecting. There are some special situations like, say, intravitreal gas injection, where the gas should be the last that you're injecting, especially if you're doing a combined, say, a pneumatic displacement for subretinal hemorrhage or something like that. The gas should be the last to be injected. Paracentis is a must before injecting. Turn the head appropriately to prevent any sudden regurgitation of the gas, and prevent fish mouthing by injecting smoothly. For ROP, again, the safer protocol is sort of a mnemonic that can be remembered, where S stands for the short needle, so it should not be more than 4 millimeters in length. So use a stopper if you can, so that it doesn't go too much inside. Then antiseptic and antibiotic use is even more important, especially in children. F stands for the follow-up, where you need to look at the eye within 48 to 72 hours post-injection to prevent any bad occurrences from happening. The extra attention is to inject 1 millimeters behind the limbus, and not 3 millimeters like we do it in adults, because these are, of course, small eyes. And then R stands for recheck, where you recheck for every week after injection for vascularization. So what we discussed now was patient counseling, sterilization, that is giving injections in the OR settings, loading the drug and looking at certain checklists before loading and at the time of loading, preparing the eye with betadine and some disinfection there, then some anesthetics, which makes it as painless as possible, an actual injection where you look at the quadrant, the distance from the limbus, the direction of the needle, the gauge of the needle, that is usually 30 gauge, and you think about whether you want to use a microscope or an indirect ophthalmoscope. So overall take-home messages, counsel, treat and extend is the best protocol now. Sterilize, inject in the OR, pay attention to the autoclaving, prepare the eye with povidone and anesthetic. Actual injection, think about the quadrants, what you want to use, the scope, the microscope, distance, and the needle. And then, finally, we should all have happy patients and happy physicians. I just completed 3 years of my private practice in Mumbai, so I thought I'll share it with all of you. Thank you very much, and I'm happy to take questions if you have any.
Congratulations, Dr. Sengupta, for completing 3 years of your anesthety, hospital anesthety, and thanks for your wonderful lecture. So we have a couple of questions for all the faculties who are here. So first question is, should inject in treated scarred macula with again present with the submacular hemorrhage without any fluid? So probably I would request Dr. Parveen Ma'am to take this question.
Yeah, so as I had highlighted in my talk also, so if it's a very large CNVM, you may think that patient may not regain visually. But if there is an active recent onset retinal hemorrhage, which means it's a recently active CNVM and some sign of progression is there, then in that case, you can consider an injection of anti-VEGF. And usually these kind of membranes which are large and you have one edge of it which has started leaking again, usually you may feel that they have an underlying PCV as the cause of this kind of a situation. And then it becomes even more vital to inject, because PCV not only can rob the patient of central vision, it can take away total complete vision of the patient, and patient can become NPL, no perception of light. So then it definitely makes sense to treat. So recent progression, recent onset of hemorrhage, and if you can do a FFA or ICG to look at what is exactly leaking in that area, then you can even consider thermal laser to that area, because it is anyway safely extrafoveal.
Dr. George or Dr. Sabyasachi, if you want to add anything here.
Yeah, no, I agree completely, because we have patients who have this central scarring, but their peripheral vision is also very important. So I would agree with Dr. Parveen that if there is a fresh subretinal hemorrhage, definitely if you leave it to progression, that lesion size is further going to increase, and further peripheral, the vision is going to, and if they have a breakthrough vitreous hemorrhage or so, then the vision is going to go completely, especially in PCV.
I also agree. I think, especially, people who have treated enough cases will really know that we can't leave these to chance. So anterior segment surgeons may be, treating them on and off, but then we see these on a daily basis, and, this can really go dramatically bad, and, so definitely treat.
Okay, so my next question is, I think the most interesting and probably most debatable question is, will OCTA replace the role of fluorescence angiography, and where do you see the role of FFA, even with existing newer technologies on coming on the OCTA front? Dr. George.
Yeah, actually FFA, OCTA will replace to certain extent, at least in my opinion. Because we don't need a peripheral dynamic flow or peripheral, we only need a macular neovascularization, which can be, 8 by 8 macula. If you have a, a certain experience for segmentation, then you can pick up almost most of the neovascularization with a combination of OCT and OCT angiography. OCT angiography alone may not be a standalone replacement, but if you combine OCT with OCT angiography, except for PCV, even PCV, now we know that around 85 to 90%, if you combine OCT and OCT angiography, we can diagnose even compared to ICGA. So I would not say that OCTA is a replacement for ICGA, but to a great extent, you can get away without an FFA, because you are confirming the presence of neovascular network with OCT angiography. All subtypes, type 2, type 1, even type 3 also, you can see the network with OCT angiography.
Ma'am?
So I agree. I think where Neovascular AMD is concerned, I have almost stopped doing FFAs. I really don't do them anymore. Vis-a-vis macular edema due to diabetes, where you still have a role because peripheral view is necessary. But where Neovascular AMD is concerned, OCT and OCTA, even in PCV cases, can really do the job. And with now increasingly PDT becoming less available, even if you identify polyps, what you're going to do, you're still going to do anti. So that way, OCT and OCTA can do the job. Though, of course, if you know, it's very vital to know extrafoveal polyps. If you have, you treat them with thermal laser, your load of injection, the number of times you have to inject, that becomes substantially less if you are doing some kind of thermal ablation of the polyps also. So that ICG is still useful, because it will definitely bring down the number of injections you will need to give in these eyes.
Thank you. So my next question to Dr. Sabyasachi. So considering we are in the pandemic phase and there is a lot of new variants which are coming, and we have now Delta plus variants also in India. So especially with respect to intraretinal injection, doctor, would you recommend probably doing an RT-PCR or a rapid antigen for patients with no intraretinal injections? What is your views on that?
Yeah, so just on the previous point, like Dr. Parveen ma'am has told us that we are gravitating more and more towards monotherapy for even PCV. So then what's the point of really doing these invasive tests? But I still think ICGA will give us more information. FFA we might not do for neovascular AMD, except for maybe things like MACTEL or some very specific etiologies where it's very difficult to pick up what is leaking. But other than that, probably FFA is not going to help much. ICGA will still persist. From a PCR point of view, I think it's for the regulatory bodies to give us, proper guidelines as to how to go about. So, even now, I think I don't really know, and it varies from state to state. But I don't think there is any guideline currently for doing these tests for any intraocular procedures as of now. So, at least I don't do it. For the last 2 months, I haven't been doing these procedures. Before that, if any surgeries or even intravitreals, I used to do I used to ask patients to get RT-PCR, but it's quite a hassle, so For private practitioners especially, I probably think it's, it's not really feasible.
How about Dr. George and ma'am?
Yeah. Actually, this as our institute, we have a protocol that surgical patients all are being screened on the previous day, and only negative patients, because especially the retinal surgeries, you are exposed for a longer time period to the patient. And injections we are not currently doing, like what Sengupta mentioned. We are not injections. We are not doing. But it's up to the practitioner or whoever. It's a personal preference also to feel more secured, and I think there's no strict guidelines as such. But as to a point which Dr. Sengupta mentioned, the patient whether should be wearing a mask or not, I prefer, since we are doing it without any RT-PCR, both doctor as well as patient better be double masked, because even because you are in a close proximity. We use a drape actually, but then still it is patients also feel, I mean, that's what we have seen. Many patients feel insecure when we are taking for a injection without a mask, and removing the mask even for 5 minutes or 10 minutes during the betadine draping. And during, I feel considering taking aseptic precaution, better be both the patient and both be masked. Unlike my wife who keeps doing root canals, they have to keep it open anyways, the mouth. So
Yeah, ma'am.
Yeah, so I agree with Dr. George, and we do RT-PCR for all our surgical patients, definitely. Exposure, not only exposure time, but I think if you subject a patient who is positive or had the infection to a surgical procedure, it may tip the balance for him as well. So I have seen some patients really go downhill, though when they were asymptomatic during the time of surgery, but later on they, any surgical procedure done while they were having this infection, and it can systemically hit them very badly. So from the patient's point of view also, I think RT-PCR before a long surgical procedure is desirable. And where the injections are concerned, I think universal precautions like we take in the OPD for all patients are enough. And we also have all patients wearing a mask. So during the draping procedure, as the mask gets spoiled because of the betadine solution that we are using, so we give a change of mask at that time. And there was a recent report in the journal that because of the mask, the infection rates or endophthalmitis rates have increased because the movement of the air is above. So if you encourage the patients to use a sticking tape or plaster on the top of the mask, so that takes care of that issue as well. So, and once they're at home, they can then remove the mask, and they need not wear the mask all the time. So during the procedure, definitely, we encourage masks, and both the treating doctor as well as the patient.
Okay, great. So my next question to ma'am, so considering now we are in the pandemic and many patients are not coming to the hospital, especially the CNVM patient. So what probably Shankar Nethralaya kind of strategies are following to follow up these patients and still protect their vision, considering the CNV, there's a chance of irreversible blindness is very high if there's missed follow-up. So any tips on that?
So number one, we never really stop treating the neovascular AMD patients. I think the AIOS guidelines and the VRSI guidelines were also there to help us, which said that these patients have to be taken and they have to be treated. Number two, I think if at all there was any hesitation on part of retina specialists to use the treat and extend protocol, I think that was taken care of. All of us now believe, now that the patient has come, let me treat and then call him later for an extended period. So I think the treat and extend has really got enforced during this COVID or pandemic time. So that is another change which has happened. No more we are doing PRN because patients cannot come so frequently. Patients cannot come on an emergency basis. There may be a dropout. So that, and another thing which I mentioned during my talk also, I think we are almost there with the use of a handheld OCT. A self-monitoring OCT device is, I think, almost there, and we should have a wider availability of that. And that would really help, because at least if they can monitor and do the self-OCT and teleconsultation can be done. We have done a lot of teleconsultation for our outstation patients. So it is a channel which allows us to not only talk to the patient, but they have a checkup done with our with the Titan Hub optometrist. So we have involved them. So we have Titan eye opticals everywhere. So they go, they have a vision check, and then they upload all their scans which they have got done locally, and we can see those OCT scans. So at least if they are stable or not really worsening very badly, we can advise them to come a little later. Or if they need an injection, we tell them that you go to that person. And I think the company people have also helped us there, because the patient health program is now almost universally available in the country. So even if you have had 2 injections on in one city, you can have the 3rd injection elsewhere, and this is still helping. So I think a lot of coordination has happened between ophthalmologists, which was not there earlier. So I think this is one positive out of this pandemic for me.
Yeah,
So,
yes. I agree completely. The treat and extend is ideal for COVID situation, ideal for a long distance patients, as we see many of the neighboring state patients, ideal for long distance, ideal for educated patients, and ideal for old age patients. The traveling is a consideration, and so these 4 groups I would definitely, especially in COVID times, treat and extend has helped many. Experience in last 1 year is many PCV patients, despite all this, we have been trying to reduce the exposure to the patients. Even OCT, even all the patients need not be an extensive evaluation in the clinic. You can just for an AMD patient, it's a review, just about dilate, get an OCT, you can visual acuity, you're done. You can reduce the exposure to fasten up the procedures actually. So despite, because of the patient fear, many PCV patients have blood, and in the last 1 year they come because of that is always there. That's all.
okay, so my last question before we close, we are on time. So, so since most of the general ophthalmologists are attending the session and some may are practicing retina, would you recommend a loading dose? I would probably ask Dr. Sabyasachi this question. In Neovascular Amd.
Yes, I mean, I think it's a no-brainer now that monthly for 3 months is a given for whatever indication we are looking at. Be it neovascular AMD, be it vein occlusions, maybe DME. It's still you can do it. Maybe a PRN from baseline, but still not recommended. There are plenty of studies which show about 30% patients with DME do well without a loading dose, but 70% still require. So majority still require. So a loading dose is a no-brainer, whatever the underlying condition is. Following that, then there are these other options where treat and extend is definitely the best choice for neovascular AMD, and the rest we can have probably another whole webinar where ma'am and Dr. George can talk at length about how to treat these. But for neovascular AMD and all other indications, the loading dose I think is a must. Whatever the condition, whatever the initial drug of choice, a loading dose is a must.
Okay. Okay, so thank you all the speakers, Dr. Praveen Sen, Dr. Sabyasachi, Dr. George, Dr. Dinesh, and Dr. Darius for the great lecture. It's really enlightening for a general ophthalmologist point of view who are passionate to learn retina. Thanks for enlightening our audience. So thank you so much. We're signing off from the session.
Thank you.
Thank you all doctors. Thank you so much.
Thank you.
Thank you.
Thank you.
It's nice.